Welcome to the AQHI and Human Health presentation, featuring Dr. Sarah Henderson, brought to you by the Kitimat Airshed Group. So I have the pleasure of introducing Dr. Sarah Henderson, who has graciously agreed to present on the AQHI and human health. Very pleased to have her here. She is the Scientific Director of Environmental Health Services at the BCCDC and the National Collaborating Center for Environmental Health. And she is also an associate professor at the UBC School of Population and Public Health. So she's got quite an extensive background in human health, and she's here to educate us on how the AQHI are created with human health in mind.
Yeah, good morning, everyone, and thank you very much for inviting me to speak with you. I have spent much time thinking about the AQHI over the years, and I was just saying to Brittany, while I was preparing for this presentation, I realized I haven't spoken about the AQHI at all since before the pandemic, so it's nice to be thinking about it again. What I want to do today is present to you a little bit of the history of the AQHI, some of the modifications that we've made in British Columbia so that it works better in the province than it had been working, and then some lingering concerns about the AQHI and maybe eyes on the future for what might be happening with this index. I also just want to leave a lot of time for questions if folks have questions or concerns about air quality or the AQHI specifically. So I'll probably rush through this, relatively quickly to ensure that we have that time together. I'll just start sharing my screen here, and hopefully you can all see that. Thumbs up? Perfect. Okay. So, as Brittany said, I'm the Scientific Director of Environmental Health Services at the BCCDC, and that's only been for the past couple of years. Prior to that, I was a research scientist with the center. And in about 2016, 2017, we sort of made it our mission to improve the way the AQHI performed in British Columbia. And I feel I have a lot of feels about the AQHI, and I kind of have a love-hate relationship with it, but I definitely have a very personal relationship with it over the years of the work that I'm going to describe today. So before I go any further, I want to thank members of my team here, Dr. Angela Yao, Jeff Trejo, Kathleen McLean. They all worked on the analyses that I'm going to present to you. I really want to thank our partners at the Ministry of Health, Eric Taylor and Natalie Suzuki, who brought this work forward some years ago, both of whom have moved on now. And then Dr. Dave Steve from Environment Canada. The AQHI is really his baby, and that's what I'm going to talk about on the next slide. And he was very willing to work with us on some of these modifications that we've made. So, this is the paper that first described the AQHI, and it was released in 2008, although it says here it was first published online in 2012. It was first published in print in 2008. And it was this description of a multi-pollutant, no-threshold air quality and health index based on the short-term association between observed air pollutant concentrations and mortality. So the AQHI was developed based on deaths. Now, there's lots of different ways that air pollution can affect health. We may want to look at things like hospital admissions associated with air pollution or physician visits, but this paper only looked at deaths and short-term deaths. So that's one important piece of information. Second important piece of information is that this was a very urban-centric study. So these are the cities that were included in the analyses, and there are not many cities in Western Canada. There's Vancouver, there's Calgary, there's Edmonton. So that's another potential concern here, is that air quality in Western Canada is somewhat different from air quality in Eastern Canada, even in urban environments. And then the other thing we want to look at here is the period of data that were used for training the AQHI model. There were two periods. One was 1980 to 1990, and one was 1990 to 2000. That's a long time ago now. Air quality has really changed since then, but these are the foundational data for the AQHI still in use today. And what this study did was look at the relationship between short-term concentrations of 6 different pollutants and death. When they had hourly measurements available, they took the average of the 3 highest hours during the day. But back then, we didn't really have hourly measurements of fine particulate matter and other particulate matter, so they had to use daily concentrations for PM 2.5 and PM 10. And they found that when they looked at all of these pollutants, the ones that had the biggest effect on mortality were nitrogen dioxide. This is often considered to be an indicator of traffic and vehicle emissions. Ozone, which is something that forms in the atmosphere after it's been emitted from a source when the atmosphere interacts with UV light, and particulate matter. In this case, they used fine particulate matter, or particles less than 2.5 microns in diameter, which can infiltrate deep into the lungs. So those are the 3 pollutants that they used to build the AQHI. So the Air Quality Health Index is based on the 3-hour running averages of nitrogen dioxide, ozone, and fine particulate matter. And that means the AQHI is only reported at air quality monitoring stations that are measuring all 3 of those pollutants. And when we look at the equation, which is down here, and it's very mathy, and you don't need to understand it very well, but what you do need to understand is these coefficients that are multiplied against each of the pollutants. So the biggest coefficient is for NO2, the next biggest coefficient is for ozone, and the third biggest coefficient is for PM 2.5. And that means that the coefficient for PM 2.5 is only about half of the coefficient for NO2. That means that PM 2.5 does not drive the AQHI. It's really more NO2 and ozone that drive the AQHI, and that's where we started getting in trouble in British Columbia, because so much of our air quality concerns are driven by fine particulate matter from biomass burning and from other sources. In addition to this complex mathematical equation, what happens is it's used to calculate a value, and that value ranges from 1 to 10 plus. And depending on the value, there are health messages that go with it. So we consider any values from 1 to 3 to be relatively low risk, and that means please enjoy your usual activities. 4 to 6 are moderate risk. If you're somebody who is at risk, you have asthma, COPD, heart disease, other potential conditions that might affect your sensitivity to air pollution, start considering rescheduling your activities. If you're not particularly sensitive, keep an eye on your symptoms. And then as we move up, the suggestions get more restrictive, and then we have this final category of 10 plus, and this category causes a lot of confusion. I'll talk about it more as we get into the presentation, but that's really the high end of air pollution. And when we think about the health effects of air pollution, and particularly PM 2.5 pollution, I think lots of times people believe that there's a linear effect. So 10 times more pollution is 10 times worse for you. That's not actually how things go. Usually 10 times more pollution is about 2 times worse for you. So we call this a log linear shape. The effect of air pollution starts to plateau. And that 10 plus is really the point at which that plateau starts to begin. So wildfire smoke. When we're biomass smoke. When we're talking about biomass smoke or smoke from wood fuels, and that can be wildfire, it can be open burning on the landscape, it can be agricultural burning, it can be residential wood burning. The primary pollutant of concern is fine particulate matter, or PM 2.5, these particles that penetrate deep into the lungs where they cause an immune and inflammatory response that can affect the whole body. We know from lots of research that short-term exposure has been linked to cardiopulmonary health effects in local studies in BC. So that means cardiovascular and respiratory health effects. Residential wood smoke in the province has been associated with higher incidence of heart attacks or myocardial infarction. And then my area of research for many years has been wildfire smoke, and we've associated wildfire smoke exposure with almost all of the health outcomes that you can imagine. And as I've indicated before, this 3 pollutant, 3-hour running average AQHI wasn't doing a good job of indicating this smoke risk in the province. And this smoke risk is one of the biggest air quality risks that many people living in BC face. And just to sort of demonstrate this pictorially, so these are data from Kamloops in the summer of 2017, which is a very smoky wildfire season. And you can see here the effects of that wildfire smoke on a daily basis in the area. We have concentrations of fine particulate matter reaching up to about 300 micrograms per meter cubed, whereas on a non-smoky day, we'd expect them to be 10 to 15 micrograms per meter cubed at most in this region. So those PM concentrations are quite elevated compared with baseline. When we look at NO2, another one of the key components in the 3 pollutant AQHI, we don't see nearly as much a shift away from baseline, just these little blips here. When we look at SO2, which is not part of the AQHI, we see some more blips. And when we look at ozone, we really don't see anything. So sometimes you will see ozone formation from wildfire smoke, but in this particular case, this event or these weeks of events had very little impact on the baseline ozone level. So if we're looking at a model that uses this and this as its primary drivers, we're not going to see AQHI values that match up with people's experience of the actual air quality. And this kind of summarizes what we would see under smoky or somewhat smoky conditions, where we'd have AQHI values that were in the low or moderate category and really not matching up with the air quality that people knew themselves to be experiencing. So here's just some quotes that have been received over time. In fact, the AQHI can be very misleading in smoke-impacted communities and might lead vulnerable people to think things are okay when they are not. We have recently written to the BC government to outline our concerns. This was in 2017. According to the Air Quality Index in Kamloops at 11 a.m. today, the air quality was measured at 3 and low health risk. I'm not sure how it's measured, but this can't be correct. The smell of smoke is once again overwhelming, and also its visibility We cannot see we can practically not see the mountains. Politicians have been hiding behind the AQHI for years while residents choke on levels of wood smoke caused by their neighbors' wood burning and many times higher than the monitoring unit. A ban on residential wood burning is long overdue, regardless of the supposedly clean air as identified at a monitoring station. And my question is, how do you dare to lie to people on your website about the current air quality conditions, which aren't accurate at all this whole summer? So I think you can get a sense of the fact that there was no confidence in the AQHI because of these disconnects that people were experiencing with the readings. In 2016, the ministry made a change to how the AQHI worked to help address some of these concerns. And this was, unfortunate timing with respect to the elections down in the States, but we did call this the Trump and hold approach. So whenever the 1 hour reading reached a relatively high concentration of 60 micrograms per cubic meter, the AQHI was automatically bumped up to 7, no matter where it was prior to that. And it was held at a 7 for 6 hours if the next reading was also quite high. And 60 micrograms per meter was chosen here because if there's a 1 hour measurement like that in a day, there's a very high probability that the concentration for the whole day will be over 25 micrograms per meter cubed, which is the guideline value for the province. So this did help a little bit with the AQHI PR problems it was having, but not entirely, because this is how the data ended up looking. And that's really not very intuitive for most people. You can see it sort of ticking along, then it jumps right up and it holds there, comes back down again, jumps right up, holds there. And once again, this wasn't really reflective of the actual air quality experience. So this is where the BCCDC steps into the equation. What we did was a more data-driven approach. We really wanted to look at the AQHI, different indicators of the health of the population, and compare some different ways for adapting the AQHI to address these PM exposures in the province. So the Trump and hold I've already described, that's one of the things we evaluated. Then we looked at a 1 hour PM 2.5 only indicator where we chose the ceiling value of the concentration divided by 10. So, a very simple calculation. I'll talk a little bit more about it in a second here. Then we looked at augmenting that coefficient in the AQHI equation by 1.4 times and augmenting it by 2 times. And again, I'll describe why we made these decisions in a second here. So first of all, the 1 hour PM 2.5 only AQHI. So we're taking the 1 hour concentration, we're dividing it by 10, and then we're taking the ceiling value of this, which means that over concentrations of PM 2.5 from 0 to 150, this is how the AQHI would look. So it's crossing from the low risk threshold into the moderate risk threshold here at 30 micrograms per meter cubed. It's crossing into the high risk threshold at 60 and into the very high risk threshold at 100. We made these decisions based on a linear extrapolation from 2 anchor points. So first of all, that switch into the moderate threshold at 30 micrograms per meter cubed was because that's really the odor perception threshold for burning wood. And we felt that if people were able to smell smoke, automatically we should be thinking about a move to a potentially higher risk threshold because it does indicate that there's smoke in the air. And then we wanted to keep this 60 micrograms per meter cubed as the switch to the next threshold, because once again, when we see a 1 hour value that high, there's a very high chance that the day is going to be over the provincial air quality guideline. Now, these other modifications to the AQHI equation, they really come from looking at the literature and understanding how wildfire smoke was affecting health compared with other types of PM 2.5. So remember, we built the AQHI, or the AQHI was built based on air quality in an urban environment where PM 2.5 is very rarely from wildfire impacts. So we were looking at these sort of mean wildfire impact compared with what we know about the urban environment and saying, look, it looks like smoke has like a 1.5 times higher effect on mortality than other types of PM. And this is a sensitivity analysis around that, looking at some of the highest risk studies in that overall analysis and saying, well, you know, in the highest risk studies, we actually see a twofold difference between wildfire smoke and other types of PM. So we'll look at that as well. And then we took these 4 different methods of calculating the AQHI and we compared them against all-cause mortality, all respiratory cardiovascular all cardiovascular physician visits, all respiratory physician visits, asthma specific physician visits, because we know that people with asthma are quite sensitive to biomass smoke, and then dispensations of salbutamol sulfate or Ventolin, because we know that when there's biomass smoke in the air, there's much more demand for those medications. These analyses covered multiple summers and 32 of the health units in the province, most of them outside of Greater Vancouver. Again, this is another one of these plots just kind of showing how the AQHI responds to, or the 3 pollutant AQHI responds to concentrations of its driving pollutants. So here's Prince George in August 2014, and the blue bars are the reported AQHI. The black line here is concentrations of PM 2.5. We have relatively high concentrations, up to 80 micrograms per meter cubed, but we can see that, you know, even at these highest concentrations, which are well above the baseline here, the AQHI isn't budging much. Here we have the NO2. This, you know, at its highest peaks, it's maybe twice the baseline compared with about 8 times the baseline up here. And here we have the ozone, which again, at its highest peaks is maybe twice or 3 times the baseline compared with up here. And here, like if you look here, you can see these highest concentration, or these highest values of the AQHI, are happening not at the highest values of PM 2.5. They're being driven by these higher values of ozone here and these higher values of NO2 here. So we just have this disconnect. When we look at the period of interest, when only the normal 3-hour 3 pollutant model, here's how the hours fell out in the data. Very few in the 1 category, many in the 2 to 4 category, and then fewer and fewer up to the 10+ category. And then here's how the hours fall out across all of these different formulations. And what you see is the color or the percent change in a category. So when we shift to the Trump and hold, we move a lot into the 6 and 7 category, but there's not actually much change anywhere else. When we look at the 1 hour only PM 2.5, we see this shifted distribution. So now we're getting more of these higher values, and it's sort of linear up the scale. We see similar redistributions across these two reformulations of the AQHI with higher coefficients for PM 2.5. And the biggest shift is here in this 2 times the coefficient model. This is just an overview of the areas that we included in the analyses, ideas of where there are large fires in extreme periods, where there are other fires in less extreme summers, just to give you a sense of what all went into this. I don't even want to go too much into depth, but what we were looking for is the model that fit the data best. So when we restructure the AQHI, statistically, which one fits these health outcomes the best? And here's the results when we look at all summers. So for all-cause mortality or all deaths, we find that the classic AQHI is still best fitted to these data. That's the red dots. Anything in red is the best model. When we look at cardiovascular physician visits, it's still the classic AQHI. When we look at respiratory physician visits, it's still the classic AQHI. But when we get down to these asthma-specific outcomes, asthma-related physician visits and Ventolin dispensations, suddenly it becomes the 1 hour PM 2.5 only AQHI. So we've learned something here. When we're talking about asthma-specific outcomes, this new reformulation of the AQHI is a better indicator for those who have asthma. When we narrow this down to the extreme summers, so there are summers where there was a lot of wildfire activity, we still see the AQHI is best fitted to mortality. It's best fitted to those cardiovascular physician visits. But when we're talking about all of these respiratory outcomes, it becomes the 1 hour PM 2.5 only model that works the best. I don't want to go into too much of the details here. I do want to say that what we exhibited was the AQHI original formulation was still strongly associated with mortality and cardiovascular outcomes, despite the limitations that we've talked about for the model before. However, it was not the best associated with those respiratory outcomes, especially during severe wildfire seasons. And if we want to be talking to the people with respiratory conditions who are using the AQHI, then we should be thinking about ensuring that it meets their needs as best as possible. In addition to this, we also need to apply the same logic to the winter months. If you're interested in the AQHI and the wildfire season, we have a fact sheet talking all about it and summarizing some of this work. It also gives you this kind of nice translation of the PM 2.5 category, the provincial AQHI, and the health messaging and some messaging specific to wildfire smoke. I'm very happy to say that this formulation has been adopted by UNBC, and the air quality map that they're using to display the data from all the low-cost sensors across the province. So these are the purple air sensors, the air quality egg sensors, and I think it provides really good insight for anyone in the province, in addition to the actual air quality monitoring stations, which are marked here in diamond shape. So all of the data are available here on an hourly basis, and they are color coded according to this AQHI scheme that was what we had proposed and has now been adopted. So if you're not familiar with this website, I'm not going to do that now, but if you're not familiar with this website, I can put a link in the chat. All right, now moving on to wood smoke season. Oh, that's not what I wanted to do. No, that's not what I wanted to do either. There we go. Now moving on to wood smoke season. So once we'd established this for wildfire season, we backed off, and now we're just comparing the AQHI and the 1 hour PM 2.5 only AQHI plus across all of the same indicators. And this time we're looking at 20 health units across the region, 10 of which are more smoke impacted and 10 of which are less smoke impacted. So once again, here's the map. We omitted the lower mainland from these analyses for complex reasons, but unfortunately, when the lower mainland is included in analyses, it can sometimes work to dominate them, and we just wanted to leave them out of here. But these are our wood smoke impacted communities, or our more impacted communities. The ones in lighter gray are our less impacted communities. Here's similar plot to what we showed before. This is very typical residential wood smoke pattern. This is from Courtney. We see these higher concentrations overnight, coming down during the day, up overnight, day in and day out. We do not see the AQHI hardly budging, even though we're reaching concentrations of up to about 60 micrograms per meter cubed in this region. This is a tool that we use a lot when we're talking about residential wood smoke, and we call it an hourglass plot. We'll just walk you through it here. So these are the hours of the day from the early morning to the late evening, and these are the days of the year, but they're centered on the winter months. So we go from the middle of summer to the middle of summer. And in a wood smoke impacted community, we expect to see this very distinctive hourglass figure when we're looking at concentrations, where we see high concentrations of PM 2.5 in the winter months and in the early and late hours, but not so much through the middle of the day. That's a very typical of residential wood smoke exposures. So when we look at the 21 communities included in these analyses, we can split them into those that are wood smoke impacted, where we see that kind of clearer hourglass figure, and then these other communities where that hourglass is simply not apparent. Now, when we look at applying the 1 hour AQHI plus, and the shift that we see during hours of the day, this is how it plays out. So this is the percent shift in AQHI, comparing the classic AQHI with the 1 hour AQHI plus. And we see, again, in these smoke impacted communities, those shifts are all happening during those smoky periods of the day, where we see very little impact of this change on the less smoke impacted communities. And then when we look at the health data, this is a slightly different view than the last one, but what we're looking for is the better fitted model, or these gray dots. We see for non-accidental mortality, the AQHI plus is the better fit. For cardiovascular physician visits, the AQHI plus is the better fit. For respiratory physician visits, the AQHI is the better fit, but it's actually not showing a significant deleterious effect here. And then again, for these asthma-related outcomes, the AQHI plus is the better fit. Overall, we found that risk of mortality in this sort of residential wood smoke study was not significant, but other outcomes were consistently greater in the more wood smoke impacted areas compared with the less wood smoke impacted areas, and that the AQHI plus fit these data well, especially again for those asthma related outcomes. And this is just how it looks in action once it's applied in Courtney. So, rather than that first plot I showed you where, it was just kind of never getting above 4, we do see this day-to-day variability better reflected with values up to around 6. So to wrap up, the 1 hour PM 2.5 only AQHI Plus was first launched as a pilot in 2018. And then we kept it running through that winter as well. Overall, stakeholders expressed being satisfied with its performance during wildfire season and during residential wood burning seasons. The public criticism of the AQHI, which is still ongoing, is now largely related to that issue of the 10 plus that we discussed earlier. And again, I think that's a lot because of public perception that the risk would continue to be linear along higher concentrations where that's not actually the case. This was fully adopted in the spring of 2021 for British Columbia, and it is under national consideration, but the AQHI as a whole needs some rethinking. And I've hinted to a bunch of this as we've been going through. So first of all, the AQHI is still based on old data, and air quality is significantly different now than it was during the training data period. We now have the technology to report at sub-hourly levels, and users expect it because they're looking for information like on that UNBC map or the purple air map. They can get very time-resolved information on air quality from other places. And currently, the AQHI is reported every hour. So if you're starting to smell smoke at about 3:10 in the afternoon, the AQHI is not going to reflect that until 4 o'clock. So you still have a disconnect between people's experience of air quality and what's being reported. We currently still require all 3 pollutants to be measured at a station before we can report the AQHI. A relatively recent provincial review shows that we could probably quite successfully report an AQHI for stations that only have PM 2.5, and that would certainly make the official AQHI report much more available across the province. Once again, rural and remote areas were not originally included in the training data. That's kind of how we got into this mess with PM 2.5 and biomass smoke in the first place. And then the role of low-cost sensors in all of this is unclear. Not only do we have the AQHI website for the province and for the country, but we have this, UNBC map and the purple air map and these other air quality maps that are being generated from these other sensors. And I think people are really looking for ways to blend all of that information together to get a more holistic idea of air quality. So that's my email address if you're ever looking for me, and I'm going to stop sharing my screen so we can chat.
Thank you, Dr. Henderson. That was a great presentation. I appreciate it. I'm going to open the floor up to questions. If you could raise your hand virtually with your hand raising image, that would be great. I'll call upon you for your question.
It's obviously a very clear presentation.
It was a very informative presentation. You gave us lots to think about there at your last slide.
It's Robert Scotton here. Can you hear me?
We can, yes.
Well, I've been involved with air quality management in Alberta for well over 20 years and ran a number of the regional air monitoring programs. And I just thought I'd add a comment on the use of the purple air monitors and some of the portable lower cost monitors. You have a reliability issue and certainly an issue with calibration of that equipment. And when you start to look at a number of them, you can see quite a variance. And so to depend on those instruments to accurately record what's going on, you have to take that with a grain of salt. And a lot of people, the public, doesn't quite understand that, I think.
Yeah, I completely agree with you, Robert. There's better ones and there's less better ones. I would say the purple air is among the better. And we know that they degrade and fail over time. We know that out of the box they can do crazy things. You know, we're not looking at a world where we're replacing our federal equivalency methods with these low-cost sensors. At the same time, the advantages are that, you know, they can work reasonably well. They're pretty good at detecting relativistic differences, higher versus lower, and they're inexpensive, so you can deploy them quite widely and get information that you otherwise wouldn't have. So I think it's a matter of thoughtfully bringing these things together, and I'll just say another kudos to Peter Jackson and his lab at UNBC, because I think that's what they're trying to do. You know, they're taking in the data from the APIs, they're processing it to see, is this thing doing crazy things? If so, don't report it. They're applying correction factors from a constantly learning training model based on the actual FEM methods, and then reporting out on an averaging period that makes sense. Compared with, you know, the purple air map, they're reporting out on an averaging period of 1 minute or something, which with these low cost sensors can cause quite a lot of noise.
That's right.
So you're right to be wary, and I'm wary too, but there's so many potential advantages that there's value in trying to overcome some of these limitations.
I totally agree, and I understand, you know, why we use them and their value. But what I'm simply saying is there's a lot of people that misunderstand that, and that you know, if we can keep them on track to hold them in instead of getting excited about a couple of numbers that are, you know, out of whack, and to rely on those numbers is not right.
Yeah, that's an excellent point. I think you're right. As air quality people invested in air quality, we can understand these nuances, but I think a lot of people just take the data at face value.
Yeah, that's been my experience.
Thank you for your question and comment, Robert. I appreciate that. Ken, I see that you have your hand up.
Yes, it's interesting that you're looking at road dust or at smoke, but have you considered the impact of road dust? Because in Kitimat, I actually, when we were monitoring, had more of an impact on simple logging trucks moving through the gravel roads and throwing up huge plumes. We've got big construction projects here right now, and there's a lot of material being moved. How is that factoring into your analysis?
So you asked me another question about a pet topic of mine, which is road dust in BC. Most road dust is quite large. So road dust is mechanically generated, which means that the particles typically are larger than PM 2.5, and it doesn't affect the PM 2.5 concentrations too much unless it happens to be right nearby. These are larger particles that fall more quickly out of the atmosphere. Now, I would say in BC, we have a couple of different road dust concerns. First of all is just general road dust, where we do have these large construction projects. They're happening on gravel roads. They kick up a lot of road dust. The other is more specifically springtime road dust in our northern and interior communities, where traction material, hydrocarbons, brake wear get entrained in the snow over the course of the winter. And then when we start seeing thaws in the spring, all of that stuff gets resuspended into the air. We've just finished a study on that kind of road dust in Prince George, and we're like moments from submitting the paper. And what we see there is a very high concentration of heavy metals in that resuspended material that would have sort of acute toxicity implications for anyone inhaling that. I wouldn't expect to see those types of heavy metals in that more general sort of crustal road dust because of these activities. But I do think that we can use work like that to start motivating more research on road dust in the areas of BC that are heavily affected by it. Having said all of that, I just would not expect road dust to have a big impact on the AQHI unless there happened to be a lot of road dust quite near to a station.
The other thing I have heard is that in large areas adjacent to freeways where there's a lot of road traffic and heavy trucks, that the PM 2.5 goes up and there's significant connection to asthma and adverse health effects. How's that being factored in?
So that's another great question. We can only measure the AQHI where we have monitoring stations to measure it. And I've see some MOE colleagues on here, but typically those stations go in places where they capture kind of the background concentrations. They don't necessarily capture those near road impacts. We know from a wide range of other research that yes, there is not spatial uniformity in air pollution. There's a lot of what we call interurban variability, where we do see impacts along roadways, especially those that are using for trucking, that are not captured by the air quality monitoring infrastructure. So we do always have to consider that those measurements we get from that infrastructure are not reflective of the experience of all people. That's true for vehicular traffic. It's also true for things like residential wood burning. You can have a community that does a lot of residential wood burning that's actually quite located at quite a distance from where the monitor is. And I think that was reflected in some of those early comments that I read in the presentation. The folks who live in this community get quite frustrated that that monitor is not reflecting their air quality experience. So these are all limitations that we have to be aware of when we're talking about the AQHI and the air quality monitoring network in general.
And the other thing is, if you're looking at doing an overall review of the whole system, and are you going to include the rural areas and the more remote areas, you have to factor in the different health outcomes in these areas, because in a lot of cases, people don't have access to the treatment in a timely manner. So their conditions are much worse before they get diagnosed. And how do you factor those things in?
Yeah, and just to be clear, that any such review is not mine to undertake. That would be Environment and Climate Change Canada and Health Canada working together for a national revision to the AQHI. They would seek input from folks like me and perhaps some others on the call here. I think, if we are revisiting the AQHI in Canada, then folks like me would advocate quite strongly for fair inclusion of rural and remote communities and their air quality impacts and their healthcare context. So, I hope if we do revise this thing, we do it in a way that is far more nationally equitable than the original implementation.
Thank you.
Thank you for your questions, Ken. Is there anyone else who would like to ask Dr. Henderson anything?
I'm also open to any kind of air quality questions you may have. You've got me here. You got me for another 10 minutes. So if there's anything it's been niggling at you with respect to air quality and health, now's a good time.
Okay, and does anyone have a broader question they'd like to ask?
Maybe I'll ask you a question. Oh, sorry.
Oh, go ahead. Yes.
what's the biggest air quality concern in Kitimat right now?
Well, right now, it's Ken Maitland. Right now, in addition to the normal index, we also have an SO2 component added to the results calculated here. But in the near future, our LNG plants are going to start producing the next couple of years, and the nitrous oxides emissions will go up significantly. So I'm wondering how the factor for the SO2 will react to the addition of a significant amount of NOx.
And remind me, the SO2 override happens at 35 ppb?
You have to ask Ben.
That's why I did ask Ben.
Yeah, so that Kitimat is unique because the province is still testing the AQHI plus SO2 as a third option formula in the AQHI system. And so at between 35 and I think it's 185 ppb, the AQHI there would be an asterisk around the AQHI value. And that's just to keep consistent health messaging with the AQHI and what we know about SO2 exposure. So it doesn't necessarily change the AQHI value itself. It just makes sure there's an asterisk for sensitive populations to know about levels of SO2 in the air.
That's right. Okay.
Above the above SO2 concentrations of 185, I think, the AQHI would be bumped to 7. And that's,
which I think has never happened, right? Or
that's right.
It happened once accidentally.
Yeah, it's never occurred with real SO2 concentrations. Well, SO2 levels don't have never been that high in Kitimat at the 3 community monitoring stations where the AQHI plus SO2 is being implemented.
Right. Okay.
Yeah.
Thank you
for
that review. That was a long time ago. Anyhow, I hear the concern that, increased industrial activity and increased NOx into the airshed is a concern. Will that come with increased SO2 as well?
Well, there has yet to be an authorization given to LNG Canada by the Oil and Gas Commission. So the exact emissions, I think, are still unclear. But there would be, there's additional SO2 as part of LNG Canada and an additional NOx as part of LNG Canada's application. Yeah. Okay.
But you haven't seen the modeling results and everything yet?
Not to date yet.
Okay.
I have a quick question. Has anybody mixed NO2 and SO2 together to see what kind of reaction they have? Like, I don't know if that's a stupid question or not. But
I don't think they would react at all with each other.
No.
I'm not a chemist, but.
Okay. Thank you.
Yep.
Thank you for your question, Elizabeth. Is there anyone else who has a general question about air quality? Or a comment? Oh, Lorene, I see something here. Question from the chat. Are there proactive prevention actions available making efforts for green spaces to promote air quality? Are there any plans on working with land planning?
Again, this isn't a question I can answer because I don't live and work in Kitimat, so I don't know what's being planned for the region. I will say that we're increasingly learning that green spaces provide protection from air pollution in a variety of ways, and urban green spaces have a lot of other co-benefits as well. So I certainly hope that kind of work is happening in Kitimat, but I can't speak to the actual local context.
Thank you for your question, Maureen.
I could maybe add something. A few of us have tried to get areas protected as carbon sinks and such like. The council for the last few years has been unwilling to protect areas because they might need to use it for something else at some point. So that's where it stands at the moment. The new council might do something different.
I live in Mission, and I can say that we have very similar conversations in Mission. So I guess I'm not surprised to hear that, but I would still urge you to continue trying to protect some of those green spaces for the health of everyone who, will potentially live in Kitimat now and in the future. Can you get a copy of the Prince George dust study? Not yet. That needs to go through peer review. We shared it with our partners at the Ministry of Environment, but once it is published, I will be very happy to send it along.
Do you know when this study will be available?
It depends on the peer review process. So it's a very academic process. We're going to submit it to a journal. They're going to review it. We're going to revise it. They may review it again. Sometimes that process takes about 3 months, and sometimes it takes a year. It just depends.
Great, thank you.
I don't even know where you'll find it when it's available. I'm hoping the first journal we submit it to, which is Toxics, but it could get rejected from that journal. I'm very happy to talk about the results. I just can't share the study at this point.
Okay, thank you. All right, we have 3 more minutes here. Anyone else have a question that they'd like to bring forward?
I just checked the ministry website just to make sure I gave you correct information about the AQHI plus SO2. And there's one other thing I thought I would just add. So in the so if the AQHI value is between 1 and 3 and SO2 concentrations are between 36 and 184 ppb, that's where there would be, you'd see the AQHI value and an asterisk on the side. But if the AQHI is between 4 and 10, then, and the SO2 concentrations were between 36 and 184 ppb, there wouldn't be an asterisk, there would just be the normal AQHI number, and that's because the messaging is the same.
Yeah.
And so then, yeah. So yes. So, but at any point, if the AQHI is 6 or less and SO2 is over 185, that's when the SO2 AQHI would be displayed at 7. So it's a little bit different than what I said before, and I will post a link into the chat right now, so you can go and to the ministry website where we have a full description of that system.
Thanks for the reminder, Ben. Again, it's been a while since we worked on that, but I'll just add that there are a few of us here who receive an email anytime any of these things are triggered, and in the past few years, anyhow, that those levels in Kitimat have not, that
right.
hasn't been triggered very often at all.
Yeah.
That doesn't mean we don't need to worry about a future state with more SO2, but overall, that system hasn't been needed very often.
Thank you, Ben, for providing that information. We've got 1 minute left. Does anyone want to squeeze one more question or comment in before we log off?
I just want to squeeze in the link to the UNBC map, which I promised I would provide. There it is.
Thank you very much.
You're welcome.
You have it there. Well, thank you very much, Dr. Henderson, for presenting to us today and taking our questions and our comments. That was very educational and very much appreciated. You've given us a lot to come away and think on and learn about. And thank you to everyone who attended today. We appreciate your support and your eagerness to learn more about air quality and human health. And so with that, we will log off of our meeting, and please reach out to me. I can connect you in with any of our participants here if you have a question or a comment that you would like to have addressed after. Thank you for joining us today. For more information, please contact KAG at www.kitimatairshed.group.com. We look forward to hearing from you.